Next, we have Dr. Gaurav Luthra speaking on when and how does anterior capsulorhexis stare and how to proceed with surgery.
Thank you, sir. Suven, very nicely done, and I don't need to show the brand littles anymore. I mean, you gave some amazing pearls for how to keep the rhexis intact. So, uh, I'll start with this situation. There's an ICL in situ. This patient came 7-8 years after ICL during the COVID times following vaccination with bilateral uveitis, a very severe one, and hypopions actually. And over 3 to 6 months, as we treated the uveitis, she went on to develop bilateral intumescent cataracts, and pupil was rigid, and we had this challenge to operate this patient, and the trick was, of course, to get the ICL out first and also to stain the capsule, and it's because it's an intumescent cataract. We wanted to be sure that we don't have a complication, and also patient had astigmatism, which was corrected with the ICL, and once that goes, we wanted to correct it as well. So a tricky situation, and since I plan to stain and I don't like viscoelastic when I'm staining, I'm using infusion in my left hand and no viscoelastic at this point, trying to ease out the ICL. And once with some manipulations, I am able to get the ICL out of the sulcus and into the chamber, and then stain under the ICL to get stain on that capsule, because I will need good contrast. It's an intumescent cataract. Get the ICL out, and once the ICL is out, I'm now ready to decompress this lens. I want to make sure that it doesn't go into a flag sign, so I'm going to just decompress it a little bit, and let's start playing from here. And I want to just go in and aspirate, but then sometimes it doesn't give you that much time. It still went into Argentinian flag sign anyway. And now, of course, you have to do the best. It's a soft cataract. It's a young patient. She's about 35. And now you can convert this into a rhexis. And of course, then you have to fashion a rhexis out of that. There forms one side and the other side, and then you can complete the surgery. But how can you preempt this? So of late now, when I am dealing with such situation, I was lucky I could get away with a toric IOL here because the axis of implantation was such that it would remain away from the area of the broken rhexis. But for the second eye of this patient, which also had almost a flat vault with an intumescent cataract, not as intumescent as this one, but still fairly intumescent, we went with a femtosecond laser assisted surgery. And you can see that the femtosecond laser can detect the ICL as the anterior capsule of the lens. So here you'll see that that ICL is sitting in situ, and then the landmarks are all gone haywire. So you have to set them up. Here it's detecting the iris actually in this plane rather than that plane. So you set that right. It also detects the pupil as the edge of the ICL. So you have to reset all those things. So not important messaging here regarding that, but frankly, you can actually then do a very good rhexis under the ICL, and that will ensure that you still get a good rhexis. And so anyway, we've managed to do this, and let's not waste time on this, but that's just one way. Now, Suen has already shown some of these recovering of the running out rhexis, so I'll bypass these, the brand littles also, and go to something which happens sometimes. Now here I'm going again, it's an intumescent cataract. I'm trying to decompress. I'm not holding the globe with the left hand. I don't like using forceps on the conjunctiva, but you need to stabilize the globe, and you'll see what happens if you don't stabilize it. And I thought my needle was sharp enough. I like to go in from a closed paracentesis chamber with full viscoelastic inside to decompress the lens and just see what happens. There will be a sudden entry. There goes, and it goes and punctures and makes a radial incision on the capsule. So now I'm having a radial incision there over there, and I have to bring it back. So there is this long, incision from the 26 gauge needle that I was using. So I anyway still go in and make a fresh entry. It's an intumescent cataract, and make a small initiator rhexis kind of a tear, aspirate some of the cortex and decompress the lens, and then I'm going to go with this forceps and microrhexis forceps and try to go around that radial tear if I can. So, going from two sides and going beyond that and kind of coming from two sides, and if you have a small nick in the capsule can be a good thing. So this is how you can deal with it, and some brand littles kind of maneuvers here to bring it back. Fill in viscoelastic when you have to. And of course, make sure that you have removed the decompressed the lens. So I was lucky I got away with this, and I was able to complete this surgery. This happened to me in live surgery. You can see on top left, I was starting off this case. I think this was in Amritsar. And as I started this surgery, you'll have to excuse me because I just couldn't find the edited version, so I've just brought in the raw video for a moment. Now, I went in with an MVR. Now, I like to use an angled MVR. And I forgot to carry my own knives there. And angled MVR, that too has to be very short part. The bent part should be really, really short. And it should be angled at the right, 30 degrees or whatever, so that it doesn't point towards the lens. And I got a blade which was not very sharp. It was straight. It was a straight MVR. And I hate straight MVRs because, they are prone to, cause problems if the patient, there's a strong bells or something. So just see what happens. I go in, and because it's not sharp, it just goes and punctures it. Now I have a very peripheral puncture. It's going all the way till there. So if I have to retrieve this excess, and I have like 5 top surgeons standing all around me trying to give me advice how to go about this surgery. And each one of them has different advice. So I tried to do something about it, and I went ahead with my other incisions, thought for a while what I should do, tried to see if I can hold on to it and bring it in, but it wasn't. It was almost radial. So there I'm trying to do something about it, but it doesn't go the way I like it. So then I start initiating a rhexis from elsewhere. When nothing else works, I thought that I'll go around it, but eventually what we did was we let that small break be alone. We made a rhexis as usual and just ignored that small puncture in the periphery. And we were able to, because I was not using any forces in that area, at the end of surgery, I was able to actually do everything right. I'm sorry, it's not, contrast is somehow not good but at the end, I had an intact rhexis. I had a puncture there. Frankly, it did not extend, and I was lucky I got away with it. So yeah. Now again, he's already shown you a few things. I'll just show you. In this patient, I had a rhexis which was, I was somehow getting a small pupil and I was managing it. And here it started running out over here. And I had no space. I was trying to use the micro-rhexis forceps, but it wasn't allowing me. And I then used an iris hook because I tried to use a Y-tip manipulator to move the pupil to the side, but this was just under the main port, so I had no access, and I was using the side port for my micro-rhexis forceps at that point. So sometimes if you get stuck, you can just use something to retract the pupil, and it'll just help you complete your rhexis and get away with it. I'll bypass this and come to a broken rhexis kind of a situation. Now this patient had a hard brown cataract with a very fibrotic capsule, something like what Suen was showing in that Morgagnian cataract. You can see these fibrotic bands over here. And I was trying to see if I can make a rhexis over there. And since I could not proceed over there, I started from the other side. Now, when I reach this point, it again is difficult because it's going to break there or it'll run away or something. So I then initiate a small second nick over there and then come around and bring it in from the other side and manage to then complete it somehow. And this is a hard brown cataract, so I need to have a slightly bigger rhexis. You can see that small fibrotic band there. Yeah, and I've completed it, but this leaves a suspect area. Now I proceed with surgery, but at this point, everything is going great for this time, but there's a lot of lateral separation required. My rhexis is not big enough. It should have been even another millimeter or two bigger in size. So you'll just notice that as I'm going through my cracks, and there the rhexis breaks from that point where I had that small fibrotic thing. So just keep watching. Just watch that area. As I do lateral separation, my rhexis will just give way somewhere here. And this lateral separation, and it just goes out. So these are weak points. So what I'm trying to convey is, sometimes your rhexis will have weak points. Either you'll have a small notch on the rhexis, or you'll have completed the rhexis from one way or the other, or you'll have some fibrotic band. And if you do lateral separation or maneuvers in that area, you have to keep away from those areas and not let forces transmit to that place. Otherwise, the rhexis will usually give way from those areas, and then you'll be in a situation. And sometimes if you are having a small rhexis, it's a good idea to give a small nick and enlarge it anyway, because trying to proceed with a very hard cataract with a slightly smallish rhexis, you will eventually put forces on the rhexis. So I realized that there was a rhexis break, and then I went a slow motion phaco, and very gradual, then small pieces, and then getting each one out. It's laborious. pupil starts coming down, but eventually you will get it. And as long as the flap motility sign is with you, which means that the flap is motile and is moving freely and it's pointing upwards and out, you're lucky and you'll be fine. But yes, if you're not conversant with good phaco, you should convert at this point. If you are very comfortable with doing phaco in very challenging situations like these, then you can still stay on, but otherwise you can convert. I think I have a minute left or I'm done. I'll just show one last case, okay. So this was a patient referred to me. Somebody had started a surgery and had a runaway rhexis, was a learner surgeon and didn't want to pursue it further. So I had referred this patient to me, and there was a run out in this area. I will go in and try to check if I can retrieve it, because if there is still possibility of bringing it back, I would like to do that. But I realize that it's gone too far, so I will initiate. Now there are two ways to do it. Scissors would be a great way. Sometimes I just do this and I'll still get a flap, but a scissors is more definitive. I would recommend anybody wanting to do this should use a scissor. See, I wasn't able to do it, and then I'm just coming inside, and maybe this is not the best direction in which to give that cut, because it should be slightly parallel to the area where you're planning to do this, not radial. And then you try to fashion a bigger rhexis than you would normally do, because now you need more room. It's a runaway rhexis, and maybe it has gone to the posterior capsule as well. We won't know about it till we start surgery, and that's where the flap motility sign will come in handy. So complete that over there. Try to make as much of a rhexis as possible and leave that weak area. Don't do any manipulations over there, and you can see that the flap motility sign is still, as I said, it's with us. The flaps are, twirled up, and the moment it goes to the posterior capsule, they'll just, turn inwards and go down. So there you can complete the surgery. I think I'll stop here because there are lots of good talks to come, and Haripriya ma'am is already here, and so thank you so much for giving me this opportunity. I'll be happy to answer any questions, and then I have to.
Thank you so much, Gaurav. That was very challenging, but also at the same time very practical.